Dr. Tariq, people are already joined.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody. I'd like to, on the behalf of the Society of Saudi Critical Care Medicine, I'd like to welcome Dr. Ja'far. He's Associate Professor of Medicine and Infectious Disease at Johns Hopkins University School of Medicine, Aramco. This is going to be our first online presentations. It's going to be in regard to COVID-19. And I would like to thank you, Dr. Ja'far, for being with us. I know you have been busy and a lot of commitment. I'd like to thank you, Dr. Sami, for facilitating Dr. Ja'far to join us, and Dr. Hani for your support, and also the Society, Saudi Society of Critical Medicine for helping us run this one. Maybe most of you could just put their mic mute, so at least we avoid any noise. And inshallah, we are going to continue having this activity. Probably is going to be, inshallah, on a weekly basis, every Saturday. Maybe the next presentation is going to be by Dr. Hani Timsah, inshallah, next Saturday. It will be announced later. But thank you very much for everybody. Thank you for joining us. I'm sure all of us will get benefits from attending this special talk. I leave the mic now for Dr. Sami Al-Majid, who's going to moderate this session. Sami.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. It's really my pleasure to introduce Dr. Ja'far Al-Tawfiq. Dr. Al-Tawfiq is an adjunct associate professor of medicine and infectious diseases at the Johns Hopkins University School of Medicine in Baltimore, Maryland, USA. He is also the chief of infectious diseases at Johns Hopkins Aramco Healthcare, and he's also Johns Hopkins Aramco Healthcare's COVID-19 response incidents commander. He has been recently appointed as a member of KSA National COVID-19 Committee, reporting directly to the Royal Diwan. He's going to speak to us today with the title of Still Early Day to Assess COVID-19 Impact on Children. Please join me to welcome Dr. Ja'far Al-Tawfiq.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Sami, for the introduction as well as for the facilitation of this presentation. And I would like also to thank the Pediatric Society for Critical Care for hosting me tonight to talk about the current situation and our understanding of COVID-19 in children. Before I start, I would like to let everybody know that I am an adult infectious disease physician, not a pediatric, but since the emergence of coronaviruses initially in the Kingdom of Saudi Arabia in 2012 with the Middle East Respiratory Syndrome coronavirus, I had been extensively involved in the epidemiology, clinical presentation, as well as control of both the MERS-CoV and the COVID-19. As we know that this, for so many years, we had been preparing in many of the healthcare organizations for such occurrence of a pandemic. I think many people had thought that the next pandemic would be an influenza virus. But in 2019, the end of 2019 and beginning of 2020, we had witnessed the increased number of cases caused by COVID-19. And this slide just shows some outline of the initial the timeline. And I think it had been so dramatic changes over the last 3 months or so since the initial announcement of cluster of cases of pneumonia initially, there were a number of cases that have not been identified from an etiology and were initially identified in Wuhan, in Hubei, in China. And those clusters was initially in December 30th, it was almost at the end of 2019, but it had been only a few days till a novel coronavirus had been isolated, which is in January 7, 2020. All those cases had been linked to the Huanan seafood wholesale market, which was closed in January 1st, 2020. Subsequently, the cases imported in Thailand in January 13, and first case was reported in Korea in January 19. And 3 days before that, there were cases that had been reported in Japan. And subsequently, I think each one of us had been overwhelmed with the number of information as well as the timeline that is very difficult. But I think what is very important to notice that it took the scientists around the world only a few days to identify the causative agent of this cluster of pneumonia had been able to made available in the website all the genomic sequences. And this slide is a very busy slide, but if you concentrate in the upper part of the slide, these all in red, these are the different isolate of the 2019 novel coronavirus. And that was the initial name that had been given to the virus. And later on, the International Society for the Nomenclature had changed the name from 2019 novel coronavirus to SARS-CoV-2, or severe acute respiratory syndrome coronavirus 2, which is the causative agent, and the disease it caused had been named as COVID-19 from CO for coronavirus, VI for virus, and D for disease, and 19 because it emerged in 2019. And I have been multiple times asked by different individuals why it has not been given the name of the city or the location where this virus had been identified. And I'm not sure if everybody is aware that the World Health Organization recently, a few years back, had made a decision and recommendation that any viruses, bacteria, or the alike will not be called after the individuals who have discovered those viruses or the animals if they are the host, and will not be also named after the cities or countries in which the viruses or the microorganism had been identified. But it's very important to note that the SARS-CoV-2, or here in the slide is the 2019 novel coronavirus, had been sequenced and is closely sitting between a bat coronavirus as well as the SARS-CoV virus, which is the initial SARS that had emerged also in China in 2002. And actually the homology between the SARS-CoV-2 and SARS coronavirus is almost 75%. And it is a little bit far away from the MERS-CoV. And this graph is called a phylogenetic analysis. So it tells us how related are those different viruses to each other, which may take some time for individuals maybe to understand, but it's usually a very simple way of looking at those viruses. As we know that the different member of the viruses and the SARS-CoV-1, if you would like, and SARS-CoV-2 and the MERS-CoV virus are these viruses that had emerged since 2002. But even before that, we have four known viruses, which are illustrated in these slides. These are the human coronavirus 229E and the NL3, OC43, and HKU1, which are viruses that had been discovered in the early 1960s. And these viruses cause the usual common cold in humans. However, all of them had been originating in animals. For the SARS-CoV-2 and MERS-CoV, our understanding are these probably had originated in bats, but then they have an intermediate host. And for the SARS-CoV, which emerged in 2002, is the civets have been identified as an intermediate host. For the MERS-CoV is the dromedary camels. And for the SARS-CoV-2, there have been multiple studies which show maybe have been related to pangolins or other intermediate hosts. And I think this is a very classic for these zoonotic disease where they spill over from the animal population to human, and they subsequently jump from the humans to be more adaptive to humans and be transmitted from a single patient to multiple patient, or what we call a sustained human transmission, which had been clearly identified. This slide showed some of the timeline for the COVID-19 in the Kingdom of Saudi Arabia that had borrowed and recently published in the Journal of National Science of Medicine. And you can see that the first case had been identified in the Kingdom was in February 3rd. And since then we had in March 2nd, and subsequently the multiple cases had been increased, and I'm sure people had been watching the news. I think it's very important to understand that I think the Kingdom of Saudi Arabia had done an excellent measures. These are measures had brought the number of the cases have been outlined in this slide from social distancing, from preventing the mass gathering, which is the main cause for the spread of the SARS-CoV in multiple countries around the globe. If we look specifically to the World Health Organization and looking at the number of the cases, and we don't have probably the full picture of all around 1.4 million cases that had been reported to date. But these are some of the data specifically looking at the COVID-19 or SARS-CoV-2 in the pediatric population. From the World Health Organization data that had been released, looking at the percentage of pediatric cases from the cases that had been reported in China, and this was the World Health Organization mission report, showed that around 2.4% of all reported cases in China had been in children, which is not a very significant percentage. The table shows the different percentages of the children between 0 to 9 years and 10 to 19 years. I know these individuals who are between probably 14 and 19 is considered an adolescent here in the Kingdom, and there are probably different age group between the transmission between pediatric, adolescent, and adult. But the point to make is here is we look at 0 and 9 in China and as well as in Italy, those children constituted less than 1% of the total cases that had been reported. It's around also the same, which is around 1% in those individuals who are between 10 and 19 years of age. If we look in this slide about the epidemiology of the cases in the first confirmed cases, which are more than 2,000 in China. And we look at the same data that we had looked at. Those individuals between 0 and 9 constituted 0.9%, and those individuals between 10 and 19 constituted between about 1.2% of the total population, with a percentage of death and the case fatality rate to be very low in the pediatric age group. If we look again, another slide looking at the demographic characteristics of individuals, and these are data taken from a contact-based versus a symptom-based surveillance. In the contact group surveillance, about 14.9% were between the age of 0 and 9 versus 2.1% independent in the symptomatology, which indicate to us that many of the pediatric age group were being asymptomatic. And that's also true for those individuals between 10 and 19, with 5.7% if we are depending in the contact-based surveillance, and symptom-based surveillance, 5.7 versus 2.1%. And I will come back to the percentages of the severity of the illness in the pediatric age group as we go through this presentation. If we look at the attack rate among the pediatric age group specifically, and this slide showed the spectrum of the age category between 0 and those who are more than 70, but I will concentrate in the first two line graphs in the left side, looking at those pediatric between 0 and 9 and 10 and 19. And you can see that if we look at the attack rate, which is very low, proportion, probably 10% or so, and those individuals which have severe disease is also very low. If we look at those, which is the green line, and this is the square indicates the mean, and the lines indicate the 95% confidence interval that we find also not all children would present with fever. In another large study looking at 2,143 children with COVID-19 infection that had been reported by the China's Center for Disease Control and Prevention, and the data were extracted between January 16 to February 8 of this year. There have been 1/3 were confirmed with a laboratory test for COVID-19. The 1/3 were confirmed with laboratory, so the other 2/3 these have not been confirmed as COVID-19, but they were based on the presence of symptoms. And 90% had illness that was asymptomatic, mild or moderate, and the rest had been severe disease. Out of those 2,100, only one child have died, and 90% did not have shortness of breath, did not need an oxygen or ICU admission, which again indicating that those individuals had been mildly symptomatic or asymptomatic individuals. This is a very busy slide, which I tried to summarize the median and the interquartile, but looking specifically at those individuals less than 1 year of age, 1 to 5 and 6 to 10, we could see that the majority of the pediatric patients, dose less than 1 is 17.7, 1 to 5 is 23%, and 6 to 10 is 24%. But we look at the severity of the illness, as I had alluded to. We look at the mild is 50.9, and those with moderate are 38.8%, and it's only a minority or a lower percentage of those individuals had severe or critical illness, 5.2 and 0.6 respectively. There are some differences in the severity of the illness based on the age group of the patient. So if look at those individuals less than 1 year of age, we look at the symptomatic is 7.4, and the asymptomatic increased to around 32% in those between 6 and 10 years of age. But the mild disease had been kind of similar, around between 15 and 22%, and the moderate disease is variable between 15.3% in those individuals who are less than 1 year of age, and reach about 1/3 of those individuals who are between 1 and 5 years of age. The moderate disease is probably paralleling those of the mild disease, and those individuals with the severe disease had been around 1/3 of those individuals less than 1 year, and those between 1 and 5 years. So 1/3 of them had a very severe disease, and I think that's an age group that we should be very vigilant in assessing those individuals correctly when they present to the hospital. This slide shows from a recent study that is still in the electronic publication in the Pediatric journal, looking at the prevalence of critical disease. And this, the severe disease or critical disease had been higher in those individuals, as we just shown in the previous slide, which is around 10.6% in individuals who are less than 1 year of age, and 7.3% in those individuals 1 to 5 year of age, and 4.2 in those between 6 and 10 years of age. And it kind of had been similar percentages of severe and critical disease in those who are between the age of 6 and 18, with slight differences. So looking at this graph, actually it shows that there have been a gradual reduction in the percentage of severe and critical disease based on the age of the child. So the younger the children, especially in the first year of life, they tend to have more severe and critical disease than the other individuals. Most of the data that I had discussed and showed in the last 20 minutes or so had been from China, but this is a new study that had just been released in MMWR, Morbidity Mortality Weekly Report from the Center for Disease Control and Prevention in the United States, looking at the age of the patients and the number of the cases. And we could see in the graph that had been an increase in the number of cases over time as the pandemic progressed in the United States. of America. Looking at the severity of the patient, and the red section of the bar indicates those individuals who had mild disease, the blue, those individuals who have severe disease, and the can-flight blue is those individuals who had, or children who had severe disease. So you could see that the majority, and in the vertical axis is the age group, and in the upper y-axis is the on the upper x-axis is the number of the cases. You could see that as we seen in the data from the China, that those who are less than 1 year of age tends to have more of a severe disease and critical disease compared to an older children between the age of 10 and 17. If we look at overall COVID-19 fatality rate, and I think there's a lot of discussion about the case fatality rate and how the case fatality rate had been calculated. Ideally, you would like to have the case fatality rate being calculated based on those individuals who had recovered from the disease. Otherwise, this may be known as an infection fatality rate, but just going with the had been published in the multiple journals and websites, that the death rate from the all we could see in the pediatric age group, and between 0 and 9 there have been no fatalities, and those between 10 and 19 there's only 0.2% death rate for those individuals. This data looking at the symptomatology of children, and this is from the same study that I just mentioned, had been recently published in Morbidity and Mortality Weekly report, looking at the patients with confirmed COVID-19, and these are laboratory confirmed, between February 12th and April 2. So we have around 6 weeks worth of data. Looking at the comparison between pediatric and adults, and the first is the presence of fever, cough, or shortness of breath. So any of those three had been 73% in the pediatric group versus 93% in the adult group. And fever had been also higher in the adult population of 71% compared to 56%. Cough had been also higher in the adult, which is 80%, versus the pediatric group of 54%. And we see that other interesting, I think, point to keep in mind. We know this is a respiratory illness or respiratory disease, but similar probably what we have seen with the MERS, the Middle East Respiratory Syndrome coronavirus, seeing a good number of individuals may present actually with diarrhea. And there's been a recent study looking at the gastrointestinal manifestation of COVID-19, mainly in the adult population. But looking at the diarrhea in the pediatric populations, around 13% compared to 1/3 of the adult population who had presented with COVID-19. And I'm sure that you are aware also of the recent studies that, or at least case report, looking at adult patients presenting with central nervous system manifestation of the disease. This slide showed a summary of children which had been diagnosed would have MERS-CoV, the Middle East Respiratory Syndrome coronavirus, and looking at those, there had been 616 children who had been screened as contact, and only a very small percentage of them, 1.9%, had been positive. That was in a comparison to 2.2% among 4,440 adults who have been screened for MERS-CoV. I'm trying to link some of the epidemiology that we have seen with the MERS-CoV previously with the current understanding of the COVID-19 and SARS-CoV-2 infection in general. So just like we've seen in a low percentage of pediatric being infected with COVID-19 or SARS-CoV-2, we'll see that with the MERS-CoV, with MERS-COVID and SARS-CoV-2. If we look at the positivity rate in MERS-CoV by the golden and the standard diagnostic test for coronaviruses, let it be MERS or COVID-19 virus, which is a PCR, would see that 10 out of 8,032, only 0.1% were positive compared to 0.7 of those individuals who have been tested in the adult population. Most of those patients were being admitted from a referral hospital. I thought to share with you some of a comparison in pregnancy, and I think although pregnant, we don't have much of the data about pregnancy and COVID-19, but I try to summarize in this editorial that I had recently published in Tropical Medicine and Infectious Disease, looking at a comparison between pregnant women with MERS-CoV and COVID-19. And have been able to refer to 2 studies with COVID-19. One included 9 pregnant women and the other 15 pregnant women. The mean age had been similar between the MERS-CoV pregnant woman and the COVID-19 with no statistical significance in the mean age, but the gestational age in those pregnancy were significantly higher in the COVID-19 between 32 and 37 compared to 28 weeks of gestation for the MERS-CoV. I think similar to our understanding of the MERS-CoV, that the majority of those individuals required intensive care unit with a high fertility rate as well. That's reflected in the pregnant woman who had MERS-CoV. Around 2/3 of them had required an ICU admission. However, in one of the studies for COVID-19, there was no mention of the need of ICU admission, and 0% of the second study with COVID-19 in pregnancy were required, or none of them required to have an ICU admission. The maternity survival, and I think this is a factor reflecting probably some of the differences in the case fatality rate between MERS-CoV and SARS-CoV-2 or COVID-19, where all the maternal side had survived in the COVID-19. There have been around 30% fatality rate in the MERS-CoV. And I think that's had also reflected into the fetal survival, which is significantly lower in the MERS-CoV in comparison with the COVID-19. There will be a variable rate of C-section delivery between the different studies. Some studies with the MERS-CoV, which included the 11 patients, had 40% of those patients required C-section. And the other 2 studies for COVID-19 indicated that all of them had C-section versus 66.7% in the other study. And I think probably that's a reflection of the different practices for the C-section and the threshold to do a C-section in between the different countries. This slide showed kind of a summary of the some of the data that we understand currently about the SARS-CoV, COVID-19, which is SARS-CoV-2, and the common circulating coronaviruses and the Middle East respiratory coronavirus. So let's start with the commonly circulating coronaviruses. And these are the 4 viruses that alluded to at the beginning of the talk, where these were discovered in the 1960s. And these are usually seasonal, cyclical, and they cause the common cold. And they are known to cause 2 to 19% of upper respiratory tract infection in children, but also a large number of those, which around 30% of children with the common cold coronaviruses, if you would, had been asymptomatic. And 11 to 46% are symptomatic children have co-infection with other respiratory viruses. If we look at the right side, and this is the first of the 3 coronaviruses that had caused a global concern. And the first one is SARS-CoV that had emerged in 2000. And looking at the data from there, there have been 50 to 80% in children reported household contact. And I think that's probably is understandable if we look at the percentage of children who had been diagnosed to have SARS infection. 50 to 80% said in household contact, 2% of the children asymptomatic. That's compared to 13% in the commonly circulating coronaviruses. But the majority of those children who have SARS infection, 91 to 100%, had fever. And the case fatality rate in the adult was between 6 and 17% for the adult and 0% for the children. If we look at MERS-CoV-2, which appeared in the Kingdom of Saudi Arabia initially in 2012 and caused multiple outbreaks, especially healthcare-associated infection, and also caused a large outbreak in South Korea involving multiple hospitals. 32% were children, which been reported as household contact, and 42% of the children were asymptomatic. So here we have a higher rate of asymptomatic among the children compared to the other 2 disease entities, the severe acute respiratory syndrome and the commonly circulating coronaviruses. 91 to 100% had the fever, and I think that's similar to the SARS infection. And the case fatality rate in the adult range between 20 and 40%. And I think overall it's around 35%. And the childhood case fatality rate was much lower at 6%. If we come to the main topic of tonight, that the COVID-19 and its causative agent, the SARS-CoV-2, which appeared in China in 2019, as mentioned, 82% of children reported to have household contact. And you could see, I think, between the MERS-CoV and SARS-CoV and the SARS-CoV-2 that we have majority of children household contact. But the asymptomatic being reported to probably about 10% overall, but we have seen the breakdown for those asymptomatic children based on their age group. Looking at the clinical illness for the COVID-19, 44 to 50% of the children had fever, and we kind of went over the data from the United States that had been published in the weekly morbidity and mortality report. And the case fatality rate in adult is 0.9 to 3%, although this study put as 0%. I think the mortality rate for children, it's approaching zero, but it's not quite as zero, depending on the age group. And we had already went over detail based on the age group, case fatality rate, and the severity of the disease and the illnesses. So far we have seen had been variable, probably epidemiology in the adult population versus the pediatric population, and the different researcher and scientists trying to put some reason or reasons behind this low rate of infectivity in the pediatric age group. And some of these just because of the time, and I know everybody is probably tired at the end since it's the end of the weekend, I'm going to elucidate and highlight some possible explanation that had been brought why the pediatric age group has a lower rate of infection, either with MERS or SARS or SARS-CoV-2. And one of those is looking at the CD4 count. And they thought that in the pediatric, there have been higher number of CD4, and these are the helper T cells. And there is a lower number of CD8 in the pediatric age group compared to the adults. So they have a higher helper cell than the CD8 in compared to the adults. And these felt to be very important in the innate immunity and the natural killer cells. And I said that because just of the time, I don't want to go into the details of the immunology for those explanations. Angiotensin converting enzyme activity, as you might be aware, there are different receptors for each of the viruses that we have discussed from the corona group. And the receptor for the SARS-CoV-2, the causative agent of COVID-19, is angiotensin converting enzyme 2, which is ACE2, which is different than ACE1 because in the pathogenesis of those and the regulation of the angiotensin renal system, the result in vasoconstriction and so forth. But also they are important to have some important issues in the immunology, which may need us another time to talk into details. But it's felt that been some differences either in the distribution, the maturation, as well as the functioning activity of those receptors, which will help and facilitate the entry of the virus into the human cells and thus the multiplication. There have been fewer outdoor activities and undertake less international travel. This is one of the reasons that at least been cited for a lower risk of MERS and SARS, but probably this is not true for the SARS-CoV-2 or the COVID-19 disease, since now we have been witnessing a larger community transmission, especially the data that I have shared from China, which they had thousands of the individuals. So the outdoor activities and less international travel might not be an explanation for all of those findings. We have also seen in the previous slide how many of those individuals, either with the MERS or the SARS or SARS-CoV-2, had been household contacts of individuals. So I think there is a balance in the between the adulthood and the childhood, and this is a diagram that I just borrowed from a recent publication. Will children reveal their secrets? The coronavirus dilemma. Why the pediatric age group had a lower rate of infection compared to the adult, and I had alluded to the maybe a higher rate of the ACE2 in the children compared to ACE2 in the adult, the trained immunity, and the trained immunity in the childhood. This is the innate immunity that relies on natural killer cells rather than cytotoxic T cells, which need more of an activation. Maybe also some theoretical constitutional elevated lymphocytes, B, T, and natural killer cells as part of the innate immunity. And in the adult, maybe a reduction in the lymphocytes, B and T types, as well as the natural killer cells. This slide should how to, I think, a questionnaire that being distributed to 352 individuals of should parents, and I think every child now is talking about COVID-19. If any child had been watching and following the news, and said the percentage of US adults who think parents should talk to their children about novel coronavirus outbreak or the COVID-19, 72%, which are around 3/4 of those said yes, they should, and 14% said they should not talk with their kids about the virus. I think we should be especially careful about who has been in contact with the young children. We have to choose the caregiver carefully, and we have to limit the number and the overall contact with those individuals, in addition to the social distancing, frequent hand washing, and of course, parents as well as others in the household should stay away from children if any of them is sick or having an illness. We have to also limit probably the number of people who have contact with the young children and the household. As far as it is possible to keep the children at home, and we know that currently that for so many weeks that school had been off, to trying to avoid the crowding of these individuals. And I think the washing of the hands is very important. It might be difficult for the kids to avoid the touching of the mucous membranes in the face, which may be a port for the entry of the virus. And before I conclude, I think our time is about to finish. I'll leave you with this slide looking at the children with the COVID-19 and these all the parents having a surgical mask. Currently, there's some discussion about the universal masking in the areas outside the healthcare setting, especially in the community. But this might be particularly important when social distancing is not possible outside the house. And I thank you for your time and your patience to go over the presentation. And thank you, Dr. Sami Al-Majid and the group for the invitation.
Dr. Tawfiq, we really appreciate your talk, and it's excellent summary and very helpful for us. I receive a lot of questions. Because of the time limit, maybe we'll limit it to a few questions. One of them it is, what is the percentage of recurrence of COVID-19 after cured of confirmed cases?
I think we don't have data looking at the percent of the recurrence. There are multiple reports looking at individuals who may had a relapse. And I think we should also be careful. Some of those had been mainly relying on a presence of the viral RNA by polymerase chain reaction. And it's probably not the best to identify individuals who have recurrence. There are some reports of that, but looking at the exact percentages, we don't have a large study to give us a percent of those who had a relapse of the COVID-19. I think I said with the caveat also that most of those had been based on a PCR, which looking at the RNA, and we don't know how many of those, in addition to the presence of the RNA, they were able to culture the virus to indicate that there is a multiplication of the virus.
And one of the questions is why the death rate is higher in Italian population? Any explanation? Is it related to their immune system or their aging group?
I think there are multiple studies trying to understand the differences in the case fatality rate and why it is so different. One of the explanation for it may be related to the age group of the population. That's probably higher elderly in the Italian. There is some suggestion there may be a different variant or clades of the virus. Some people don't still believe on that since they have not showed functional differences between the different clade of the virus as compared to the genetic mutation in the virus giving them a different, but there are probably few explanation and others we are still waiting to elucidate all the factors contributing to the differences in the mortality rate.
And one of the questions also, considering our previous knowledge about other coronaviruses, is this virus considered a seasonal virus, and can we hope it will decrease with the changes in the weather and being in the summer?
Based on previous experience, as we know that the COVID-19, the SARS-CoV-2 is a pandemic, so it's a new virus, so we don't know how it's going to behave. There's some suggestion people have looking at modeling data and looking at the data of the number of cases in the different countries and compared it based on the temperature as well as other countries which have a higher temperature. And it seems that countries which have a higher current temperature, they had a lower number of the cases. So we're hoping that observation is valid and then the virus will go away as the temperature goes much higher in the different countries.
And one of the question also related to mortality. Why, as compared to Italian, Germany, death rate is way lower than Italian? An explanation?
I think we just answered that question in the difference of the rate of the case fatality rate, depending, I think, on the population, the movement, the characteristics, and maybe the presence of mildly symptomatic. And I think that's one of the area. There are some countries which had extensive testing and extensive reporting, so you are more likely to diagnose individuals who have asymptomatic disease, more likely to diagnose individuals who have mild symptoms, and thus the number of cases who have died will be diluted. And we have seen that based on the case definition, for example, initially in 2012, with the MERS-CoV, when the case definition were included only individuals who are in intensive care unit or severe cases, that you will have a very high case fatality rate. And if we were able to have a serological test looking at a seroprevalence of SARS-CoV-2 or the agent of COVID-19, and we demonstrate there is a large population who are immune or they have been infected at least, even if they are not completely immune, I'm sure the case fatality rate also would be much higher. And the different countries around the world had different testing strategies and algorithm some of them had mass testing and more kind of liberal testing of the individuals, and other countries had limited testing capacity and capability.
One of the questions is, say, the limited sitting hospital, is it cost effective to allocate resources, manpower, equipment, supply to pediatric hospital, given the low rate of infection and low rate of fatality on them?
I think this is an evolving situation. I know I said it's an early probably to go in. I think hospitals should be aware, should be prepared to deal with, because the last thing you want is having a patient, for example, get admitted and then cause a huge or a large nosocomial infection. I think we should be looking wisely at our resources. We should be ready to deal with such individuals, taking into consideration the different epidemiological variables that we had discussed and others that we did not have the time to discuss as well.
There is multiple questions also about the role of BCG vaccine, and also countries with high rate of malaria infection, given, is it a protective, and why is that?
For the BCG vaccine, and if you remember at the end of the talk, I kind of alluded to why maybe children had a lower rate of infection than adult. And one of the reasons that had been suggested is probably the innate immunity. And BCG vaccine for tuberculosis induces an innate immune response, and probably will facilitate the eradication of the virus. There are some population-based studies looking at the prevalence of COVID-19 in countries and comparing them between those who had BCG vaccine and those who did not. I think those studies, which are population-based, are always may raise an understanding or a theoretical background for further investigation. But this is the current understanding why maybe a BCG vaccine may modulate the immune response with the innate immunity and cause lower infection. As far as the anti-malarial medication, the hydroxychloroquine, these are anti-parasitic. These are not antiviral medication, but it felt that those medication will interfere with the replication of the virus by increasing the zinc concentration intracellularly, and thus prevent the RNA-dependent RNA polymerase or the RDP enzymes for the replication.
You know, there is a lot of conflicting data about using chloroquine and Zithromax. You know, just I was reading about in the article, New England, that the mortality rate, in fact, is higher as compared to a French study, which said no, it's very protective, and almost 91% of patients who was receiving chloroquine Zithromax were doing very well. Why this conflicting data? Is it too early to publish these studies? Is it population related?
Yeah, I think the jury for the use of hydroxychloroquine is still too early. There are 3 studies being published from the same group from France, looking at hydroxychloroquine and azithromycin. I think one of the maybe issues with those studies that they have no comparatory arm. So this might be difficult. I think people are interested in publishing as they know the data, but it's probably the best evidence that we have, but it's not the best evidence. So people always looking at a randomized control trial. And even the one, and I think it is officially published, I think it was somehow leaked from the New England Journal of Medicine, but none of these studies currently had been published were a randomized control trial, which probably give the best evidence. And there are multiple trials looking at therapeutics in the different therapeutic pipelines to understand the best therapeutic options. And I'm sure in the next probably 2 to 3 weeks, we'll see some of those solid studies that will enhance our knowledge about the therapy for COVID-19.
This is a political question. What about the validity of Chinese data? Are they valid as compared to other countries' data?
Well, I think the World Health Organization mission, and there's maybe a 2030 page that had looked at the data, they had validated. There's a group of scientists from around all the world who went to China, and the data is available at the World Health Organization that had parallel to the same information that we have seen from China.
What about the role of anticoagulant in management of lung disease? It's not ARDS, a completely different pathophysiology.
The pathophysiology of respiratory disease in individuals with severe and critical illness, I think there are emerging knowledge maybe of different types of individual. Those individuals which may have the traditional ARDS that we know of, and they are difficult to ventilate. There is also emerging data from Italy looking at a proportion of individuals who may not have a problem with the ventilation, but probably with the perfusion. And that's what brought the thromboembolic therapy in the line for managing those individuals, and probably using more of the IV unfractionated low molecular heparin infusion, which has more anti-inflammatory than other anticoagulants, which might not have an anti-inflammatory properties. I think it is too early to know, but there are data suggesting that maybe there are a group of individuals have the traditional ARDS and others may not have the traditional ARDS.
Dr. Jafar, again, thank you so much for your time. I know you are busy and we already exceeded the 1 hour time. We really appreciate all the attendance. By the way, it's almost 280 attending this activity, which is really an amazing attendance number. Thank you again, and I hope we'll meet you again in another lectures. We really appreciate it.
Yeah, again, thank you, Dr. Sami and Dr. Jafar and Dr. Tariq for this wonderful meeting. Again, much appreciated. We're gonna try as much as possible to upload this as a video, so others also who couldn't join, hopefully we can have them later on. Dr. Tariq, anything before we conclude? Any suggestions, Dr. Tariq?
Thank you very much, Dr. Hani, Dr. Jafar, and Dr. Sami. It's a wonderful, very appreciated talk and presentation. This is one of the first online activity for the Society of Critical Care, Saudi Society of Critical Care, and I hope that we'll continue doing this activity. Hopefully next Saturday, inshallah, Dr. Hani will give us a talk doing in regard to pulse recommendation for patients with COVID-19 patients. Please join us. Future details of this talk is going to announce later. Thanks everybody, and thank for the whole group who joining us this evening. Thank you.
Thank you again. Have a good night all.
Thank you. Thank you all.
Thank you.